Good morning and welcome to today's webinar. Pricing Transparency is here, Lessons Learned and Strategies for Post-Implementation. If you check out the events section of the chapter's website, you'll see that we publish all activities for Georgia HFMA and other chapters in our region as well. I encourage you to take advantage of the education sessions offered not only at your chapter level, but for the region as well. My name is Catherine Efford, and I am a volunteer with Georgia HFMA on the Webinars and Forums Committees. Just a few housekeeping items. All phone lines are on mute to avoid interruptions during the broadcast. Please submit your questions via the question box at any time. I'll coordinate with our presenters for their answers at the end of the presentation. You'll receive the presentation, recording, and other links for a survey and CPE credit within 48 hours via email from me. Everyone on today's call is eligible to receive continuing education credits for participating. Please be on the lookout for that information coming from me on Friday for CEU credit. Now I'd like to take a second to recognize and thank the Georgia chapter sponsors whose logos you can see on the screen now. We appreciate your support. I'll now introduce today's speakers, Christopher Kalkoff, John Asante, and Mark Spear. Chris has more than 30 years of operations, finance, managed care strategy, contracting, M&A, and strategic alliance experience across hospital, physician organization, and health plan industry verticals. Chris has also led Guidehouse's provider managed care solutions practice for the last 4 years and brings a national perspective, which includes managed care strategic pricing experiences across 100+ hospitals. Based out of Athens, Georgia, John's experience includes integrating people, process, and technology to develop innovative delivery models and promote business growth across evolving industries with a strong passion for improving healthcare delivery. John has over 10 years of experience with strategic finance analysis and managed care benchmarking and pay-for-performance programs. Mark brings more than 20 years experience leading strategic pricing, CDM, financial feasibility studies, and revenue cycle assessments. Mark is active in the healthcare industry by speaking nationally on pricing transparency issues and recently serving as the Healthcare Financial Management Association's National Advisory Committee on Payment Models. Mark has also served as past president and board member for the Western Pennsylvania chapter of HFMA and is active with the South Florida chapter. Chris, we're ready to begin.
Great. Thank you so much, Catherine. Well, I think today all of us are going to probably experience a little bit of deja vu, as many of us have probably sat through a webinar or two back in the fall on pricing transparency related to the requirements and the readiness strategies. However, fast forward to today, we're almost 3 months post-implementation, and what we're finding is many hospitals are still either analyzing how or if they will comply, or even how they can use the publicly available pricing data that's out there for strategic purposes. So during today's session, we're really going to first level set on the provider requirements, just for some folks that maybe are a little bit unfamiliar with them. And then we're also going to briefly chat about the payer requirements coming into effect in 2022, 2023, and 2024. Next, John is going to discuss some initial observations from a Guidehouse study of almost 1,300 hospitals and their varying levels of compliance, as well as looking into some of the Georgia-specific observation that his team had. After that, I'm going to quickly cover some risks and opportunities, and finally, Chris is going to wrap things up to discuss, how organizations can develop strategies to address those risks and opportunities head on to be more proactive and take advantage of the situation. Okay, so let's jump into some of the pricing transparency basics. As most of you know, on January 1st, 2021, hospitals were required to show their prices under 2 ways under the expanded pricing transparency rule. The first is the machine readable file, or MRF, containing the negotiated rates and terms for each payer. This needed to be made accessible on providers' websites. And again, it defined charges in 5 different ways. First is the gross charge. That's the charge that most of you are familiar with. It's reflected on your hospital charge master. Absent any discounts. Most folks were already disclosing this back in 2019 under the previous pricing transparency requirements. Next is the discounted cash price, which is your uninsured rate. That's the charge that applies to individuals who pay cash for a hospital item or service. Really, in essence, this is almost like a disclosure policy as to what that percentage discount is. The middle one, the third, is the payer-specific negotiated charges. That's the charge that hospitals negotiated with, its third-party payers for an item or service package. That was the most contentious of the group. And again, this was something that you didn't have to disclose your Medicare or Medicaid rates, as CMS did not consider them to be negotiated rates. And again, that's your traditional Medicare, Medicaid. Some of obviously your managed programs would be negotiated and therefore had to be disclosed. Obviously, that was very contentious because it pulls back that veil or curtain on what the hospital contracts are with the payers. We'll get into a little more of this in a couple slides. Lastly, we talk about the de-identified min-max values. Those are really a subset of item number 3. And again, I think this was something that was included by CMS as a plan B, just in case some of the court cases didn't go in their direction. Again, that was all moot, but based on what's transpired in the courts as well as the administration. So again, I think folks are dealing with this as we go along here. The next requirement is the shoppable services file, and that's the 300 shoppable services, which include a pre-identified 70 by CMS and another 230 that the hospitals had to require. Again, some folks, the smaller facilities may not have 300. Others, they didn't have all 70 and had to fill in the gap to get to 300. Again, that was basically just a requirement out there acknowledging by CMS that the average person really couldn't go back to that machine readable file and navigate the file. They wanted something a little more consumer friendly that folks could utilize and hopefully determine what a cost of service would be. Again, this was, hospitals, one requirement part of this and one way to meet the requirement that hospitals were able to use their existing patient estimator tool to fulfill this requirement, as long as there wasn't a barrier to access, such as a user login. And again, this is where a lot of providers were actually complying with the regulation or some form of compliance with the regulation. They were using that patient estimator tool. And John's going to chat more about this just in a few moments here. Another part of this slide that's kind of important or interesting is the right-hand side of the slide. And that's really about the payer requirements that are going to go into effect over a 3-year period starting in January of 2022. I think most of us would agree on the provider side, or those of us who have provider clients, that likely it was probably premature of CMS to have the providers begin this pricing transparency endeavor prior to the payers. I bet many of you probably saw some of Joe Pfeiffer's letters and articles in HFM magazine. And there was an interesting one where he was commenting on pricing transparency. And he said pricing transparency as a guiding principle is directionally correct. But hospitals disclosing payer-specific negotiated rates really it's not going to help the patients or consumers understand their out-of-pocket medical expenses, which is really the true key goal of pricing transparency at the heart of it. So it was always HFMA's contention that the payers would have been much better suited to be that source of information with the providers on the hook to provide what that self-pay or uninsured discount would be. Unfortunately, as we all know, HFMA and AHA's arguments were obviously not well received in the courts, and here we are today. So admittedly, I think many of us on the provider space have had a bit of narrow focus when it comes to complying with the provider requirements and maybe not necessarily focusing as much on the payer requirements that are coming up. So we thought it would be helpful to share or cover at least some high points from this so you have that in your back pocket. And of course, if we have folks with, anyone from the health plan joining us today as well. So starting in 2022, payers will be required to issue 3 separate machine-readable files that include detailed pricing information in a standardized format. The interesting here, and we bolded it, is it's updated monthly. That's different than the provider requirement that's really annually, at least annually. So again, that requirement is a bit of a departure from that annual requirement for providers. So the three files, they are, file one is the negotiated rates for all covered items and services between the plan and in-network providers. File two is really kind of the historical payments to and billed charges from out of network. And then lastly, it's the file three is the in-network negotiated rates and historical net prices for all covered prescription drugs. And then if you start to look, and this is probably most important for your patients, starting in 2023, the payers are going to be required to publish two key items. One, the personalized out-of-pocket cost information. So the underlying negotiated rates for all covered healthcare items and services, including those prescription drugs, and then a listing of 500 shoppable services. And again, finally, to wrap things up in 2024, the remainder of all those items and services will be required to be published by the plans for that year. So again, we probably could cover a whole session on those pay requirements, but we really want to focus today on the provider side. This next slide here, we're not going to spend a ton of time on it, but we wanted to provide it to you as a nice takeaway to show you how pricing transparency is actually one piece of almost a puzzle or a continuum of the overall data transparency rules and regulations that are really impacting our industry. So we touched upon the provider and payer transparency initiatives, but we also should familiarize ourselves with the CMS data interoperability regulations, and also the CAA, which is the Consolidated Appropriations Act of 2021, and how these acts or requirements fit into this data transparency continuum. So we provided some just a little kind of tidbits of each of those and kind of on the spectrum. A nice thing about this slide that I like, and I have to admit, I'm colorblind, so it was hard for me to see or discern the colors at first. But what we're trying to do is attempting to show by each of those key items where they fall on the calendar and where these are going to be upcoming, so you can kind of see where they're going to be on the horizon. So again, we're not going to cover this in great length, but I wanted to provide it as kind of a takeaway slide. So now John's going to go into some observations from a recent Guidehouse study that I mentioned before related to the compliance with those pricing transparency requirements, and share some observations not only nationally, but he also has some observations for the Georgia market. So John, I am going to hand it off to you.
All right, thanks, Mark. So from midnight of New Year's Eve, everyone was excited to go and see who has posted rates or which hospitals have posted their files. So we started tracking files from January 1st, and we keep going back to see any updates that have any files that have been posted since we last looked. There was an initial rush to post files, and that was very interesting to see. So far, we've looked at about 1,300 hospital websites, and the results seem fairly consistent across all the states that we've looked at. There's an overall attempt to comply. So far, only about 30% of hospitals have nothing on their sites, whether the machine-readable files or the consumer-friendly files. But there seems to be more appetite to post something for the consumer shoppable or consumer friendly file rather than the machine readable file. So that's about 64% compliance rate for the consumer friendly file, and the machine readable file is kind of lagging behind, but there's they're still making updates after the initial rush. Every now and then you see a new file pop up. The only concern there is the lack of consistency across the machine readable files. It's no two files are the same because CMS didn't provide any standard for posting the files. They simply just gave a list of requirements. So based on the interpretation, we've seen a varied number of file types that have been posted, and we'll go through a few examples that we've seen. On the consumer shoppable services file, the overwhelming majority of hospitals are using MyChart or some variant of it to comply to that aspect. Whether that's going to be approved by CMS, that's kind of up in the air at this point, because most of the portals require an actual patient subscriber information to be able to access the rates for only their health plan. The intent of the rule was to make it as open and transparent to all, regardless of without any barriers. But so far, MyChart is the overwhelming majority of tools that most hospitals are using. There are a few hospitals that have actual files, Excel or CSV files that have been posted that have 300 services, but that's very few and far in between. So looking at the Georgia market, the trend mirrors what we've seen across the country. There's more of the consumer-friendly file posted than the machine-readable file, even though the numbers themselves are slightly lower, 42% for the consumer-friendly file in Georgia, as opposed to 56% across the country. There are some regions that have posted all their consumer-friendly files. Athens, Rome, Columbus, and Macon are doing a decent job with the consumer-friendly file. But across the board, the machine-readable file is lagging behind. Speaking to across the country, the reasons why folks haven't posted is, it ranges from resource constraints. We all know the impact of COVID-19 on healthcare resources right now. It ranges from that all the way up to waiting to see what competitors are going to post. No one wants to be the first to post their rates in the market if their major competitors have been posted. And we've actually read upon a hospital that just said, well, we are definitely not posting because the rates are only going to favor our competitors, so there's really no point in posting. So we're just all waiting to see how CMS responds to this, but so far there hasn't been any official response yet. Next slide, Mark. Right, so the next few slides will highlight a few examples that we've seen in the market for the machine readable files mostly. The consumer friendly files, as I said, is mostly a patient portal where a member goes in and searches for a specific service, but most of the time it requires you to put in your subscriber information. So if you don't have an actual payer subscriber information, you are locked out of the system and you won't be able to see what your rates would be. So what that does is it allows you to shop for services within your own health plan, which is really I mean, you're not going to be able to change your health plan on the fly, right? So you're only concerned with how much your out-of-pocket expense will be if you go to facility A versus facility B. So in my mind, this works exactly how it's intended to work, but we'll see how CMS responds when they do. On the machine readable file, these are some examples that we've seen. The first one is interesting. What they did essentially is just take their rate sheets and just publish those. There are there's no service code level information. It's just the service categories. So if it's a cardiac study, which is based on a fee schedule, they publish that. And in some cases, they publish the fee schedules on a separate file, or they don't even publish the fee schedule. So that the challenge with these two examples is there are no charges in here. So that's one required field that's missing here. And it's really going to be hard to calculate or estimate the min and the max, so they are missing three key provisions on the rule: the charges, the min, and the max, as well as the the cash price or the self-pay discount. But these two examples are very common examples that we've seen. Next slide, Mark. Okay, so example C is a good one. It's easy to follow because you can take that same service code and look across the top and see how different payers are paying for that same service code. It makes a min and max calculation easy. The challenge is the difference in payment types. So if it's a percent of charge, it's really going to be hard to compare 74% of charge to a case rate if different payers are paying different, using different payment methodologies to pay for the same service. Example D is a good one. It looks like in this case, they've converted all the percent of charge rates to actual dollar amounts. So in this case, I don't know how they would achieve this if they wanted to do that for the inpatient services, because inpatient services will not be based on a CDM. It's just going to be a DRG based, and the charges will be accrued after the admission. We've seen cases where they take average charges, even though CMS said not to do that. But I mean, if you really want to convert a percent of charge rate to an actual dollar amount, that's the only way to do it. So it's really not going to be exact, but it'll be close enough. It will give patients an idea of what the rate would be, plus or minus a variance. The fifth example here, that was very interesting to see. It's the same service code across multiple lines. The data is there, but if you really want to use this file, it really requires a lot of cleaning up to get to the rates, because the payers exist on separate lines, and the min and the max and the gross charges are all kind of distributed in a weird way. But I think that the intent here is we're going to get the rates out there, but we're going to make it as difficult for anyone who wants to use this file as possible. Then the last example I was going to touch on is another one here that has the min and the max in there. They have the payers across the top. So that's also very easy to do, or very easy to track. But they have a min of 1 cent for a newborn. So it's kind of, it's almost as if you can't really trust this file, because it's not, it's really not accurate, because there's no way they're getting paid 1 cent for that service. So it's, I mean, across the board, there's general lack of consistency from all the files that we've seen. But if you're looking for rates in a certain market, you can get a bunch of files together and do, if it's one code level, one specific code that you're looking for, you can get to the rates. It's just not going to be as easy as CMS really intends for it to be. Next slide, Mark.
Great. Well, thank you, John. I appreciate it. That kind of leads us to our next section here. And based on the industry response, it's pretty safe to say that the pricing transparency is going to continue to be a challenge. So we thought this slide would be helpful as we break down some of these challenges by 4 key stakeholder groups: your providers, your payers, your governmental agencies, and finally, your patients or consumers. So providers, obviously we believe that there's going to be an improved compliance as resource constraints lessen with the help of clarity, standardization, as John alluded to, kind of that right now, it's kind of like a snowflake effect where these files look very different. Hopefully at some point in time, there's going to be automation to become more compliant, through use of vendors and just, through your EMRs, those type of things. So, however, having a strategic plan to mitigate those risks and capitalize on the benefits of appropriate appliance is really going to be key. And Chris is going to get into that just in a couple minutes here. So on the payer side of things, we know they're already scanning the market to add this information to their market intelligence of reimbursement relative to key competitors. Specifically, the BUCAs are particularly interested in this data, and is likely going to be a continued focus of their competitive intelligence that they're gathering as they're increasing their investment in AI-enabled tools, just to mine that data and use it to their advantage in the contract negotiation process. Now, CMS, we go down to that kind of lower left quadrant there. They've got a significant task as well to audit all providers for compliance and enforce corrective actions when necessary. So as CMS continues to monitor and enforce the ruling, they need to listen to feedback, answer questions, really standardizing the mechanics of the files to drive consistency is really going to be critical for their broad-based auditing. As we just saw those 5 to 6 examples John just provided, they were all over the board. Finally, consumers, and this is really at the heart of the rule. They need to become more informed around the out-of-pocket costs over time. Ultimately, the average consumer of healthcare services is going to prefer a patient estimator tool to get the clearest picture of what they can expect for those out-of-pocket costs. A couple stories I want to share. There was an interesting survey back in the fall from the Pioneer Institute up in Massachusetts. It was relatively limited, but I think it's directionally accurate. They conducted a survey related to pricing transparency and found that cost estimator tools remain mostly unused by respondents, 78%. Despite the fact that over 70% of them said they wanted to know prices beforehand. So there's a disconnect there. And another interesting tidbit from that survey, when asked, who do you trust to get your best pricing information for your healthcare? Only 3% of the respondents said hospitals. The providers were behind the internet and friends. Obviously, health plans were number one. So I think there's definitely opportunity related to the consumers, not only on the disclosure of the information, but also the aspect of change management, changing the behaviors of your patients and consumers to utilize it, which may take some time, and thinking of things differently. So let's dig into some of these risks before Chris gets into the strategies. Obviously, the first and foremost is more challenging negotiations with payers. Since hospitals must publish the min and max cash prices, including the lowest cash payment they're willing to accept, this allows payers, self-insured companies, labor unions with a low floor to start their negotiation from. And unfortunately, for many of the folks or providers on the phone, the timing of this risk could be taking place as we speak, as you have contracts, if you do have contracts currently under negotiation. Another risk here is that potentially both payers and employers could establish a narrow network, which may steer volumes away from your facility to less expensive competitors or perceived less expensive competitors based on this transparency data. Another obvious near-term risk is the compliance and potential fines for non-compliance. Now, CMS under the Trump administration stated back in December that it was going to aggressively pursue enforcement early in the process. But as the Biden administration built out their team, they're still, working through some of this. So they haven't yet, commented about what they're going to do going forward. So more to follow here. Finally, or the last couple items there's obviously the PR aspect to this. The media may compare your rates in some instances, particularly in cases where maybe there's not an apples to apples comparison, like certain J codes with no NDC identifier attached or certain supply codes. This tends to be something that there's a mismatch, and what can happen is it could potentially land on the kind of the agenda of your board of directors, and I think that's something we all want to avoid. Now, on the flip side of this too, is you could get some positive press to show that your commitment to pricing transparency, and it increases the visibility and consumer trust. I think a lot of that's going to have to do with the ease of use with some of these patient estimator tools. How simplistic can you make it? And then obviously the challenge we all know is how accurate they can be. Lastly, the consumer risk. The challenge of how that data is presented to patients so they fully understand or are aware of the limitations of these estimates and how it may impact their choices. For example, one thing we've noticed that although some patient estimators are established with good intentions, there's some nuances there, and a lot of folks were trying to get things out the door before 1/1/2021. And we believe that some of this information, say for example, you have multiple prices for the same procedure within different departments of your facility. Well, what happens is some of these tools will pick the highest price, even though that highest price may be associated with lower volume. And so what happens is you could have a perception of being a high cost provider when in fact most of your volume is at that lower price. So it's worthy of kicking the tires and seeing how that information is presented versus just being compliant. So again, I don't think, consumers are out there surfing the web for a lot of this information, as John mentioned, starting at 12:01 on January 1st. But I think in due time they will be. And I think the more you can validate, vet this information, and look at with a critical eye will be really helpful for your organization. So to wrap things up, taking all these risks into account, the industry really needs to be prepared with a long-term strategy to manage this evolving requirement and its impact on the market. So Chris is going to take a deeper dive into some of these potential strategies, share some stories about how providers can take this information, position themselves favorably in this new environment. So Chris, I am going to hand it off to you.
Thank you, Mark, and I'm going to go on visual here, so it's not just a voice from the the dark side, so to speak. One of the things what Mark and John was talking about with one of my clients is they dug in post-implementation into their machine readable files because they asked us to take a look at tweaking a number of things. Was that they had a employer in there with incredibly high, from a maximum perspective, charges. And that really skewed the whole min and max. And when we asked around the executive team, who is this employer? Is it in a contract that you have direct? No one had an answer to it. No one even knew the employer name. But following up on what Mark was saying and John, you might, every now and then it may be worthwhile, depending on where you are in the process of feeling comfortable with what you've put together, to take a look and just make sure that you're accurately reflecting, max situations that still apply, because my particular client, end of the day, wasn't really sure how this organization got in the database, but it was there. So transitioning over to some of the strategy aspects here, and again, thank you for the handoff here, Mark, is once you have the price transparency implemented, what does that mean for your organization beyond compliance? What do you do to kind of build a strategy? Can you do things to either mitigate risk? Can you do things to improve incremental volumes and revenues? How aligned is it with your consumer pricing strategy? Or does it help you migrate towards a tiered pricing? Does it help you better support your key service lines that you want to grow in the market? And so part of that is not only going through the process that you went through with your mins and your maxes and all the shoppable services and machine readable stuff, but understand where your rates are today, particularly with your largest commercial payers. Not that other payers aren't part of this process. And really understand where your rates are relative to market, because a driving goal of the whole price transparency rule, in terms from a policy perspective, is really geared towards reducing cost variation in the market for the same service. In general, larger markets around the country, like in Atlanta or in Minneapolis or Chicago, they may have 3, 4, 5, sometimes 6 or 7x between low-end ambulatory commoditized services and services provided on a hospital or an academic campus. And so it's really, geared towards that. This can create some risk for you, but also potentially some opportunities, and also what you need to do to think about where you want to reposition. So understanding where your rates are relative to your organization across your key commercial payers, and then relative to the market that you compete in, gives you a pretty good indicator about how you may need to think about adjusting your prices as you go forward, adjusting what you have posted, because you do have to update it at least once a year, but it doesn't mean you can't do it more often. Think about, how do we build this into strategy? How do we attract more consumers to come to our services? How do we attract more services into our network as a whole? And think about leveraging the second item on this slide here, the data that you have, to you can kind of look at, what are your risks? Do you have risk exposure from media? I mean, Mark already touched on this a bit on the latter side. Are there situations where you have a lot of price disparity between your significant payers in the market that can result on renewals, negotiations to move prices downward towards some lower threshold that you accept? But really thinking about, how do we enrich our strategic pricing data here that's coming out of the price transparency, and use it overall in terms of our managed care contracting strategy, our pricing strategy in general, starting to think about on and off campus price issues and so on and so forth. Then take the next step on the thing here in terms of thinking about, what does this mean relative to your shorter term managed care strategies and compliance, non-compliance issues. Most of my clients internally have everything 100% compliant. But depending on the market they're in and what their competitors are doing, there's a very strong reluctance to post everything if everyone else is not posting. And John touched on the levels of compliance that we've seen around the country. And that's part of a factor that's out there. But when you have renewals coming up in 2021 or in January 2022, how are you going to use this to inform you on your strategy and your tactics with individual payers? And then lastly, from a longer term perspective, and if you have a higher commercial mix as part of your payer mix, this is a little more applicable than if you, and none of you on the phone may have this, where one of my clients in a large metro area, just where they're located, a teaching facility, their commercial mix is down to 20%. So the concept of revenue rebalancing on the fourth item here doesn't apply so much to them, but in most organizations where material amount of your payer mix is tied to your commercial contracts, thinking about how you might want to rebalance those dollars instead of having a inflate across the board strategy. Think about, how does it align with our primary Congo service lines, or our 4, 5, or 6 major service lines that we have from a vertical perspective? How do we take the book of business contract that we have a particular payer and think about reallocating some of those dollars across the system to more effectively use that in your growth strategies, in your market positioning strategies, and your margin improvement strategies? Next slide, Mark, which I think is we've used different terms here. On here, we call it our strategic pricing and risk considerations. At other times, we've referred to this as our strategic pricing game board, but we want to point out it's not per se, when we use the term strategic pricing, really geared towards things like CDM prices, but more of a dynamic pricing model where you make decisions and you base those decisions on an analytical process that you go through, looking at different future-oriented what-if scenarios about what type of pricing do I need to have at a more of a retail level? What can I do at a wholesale level? What is my network that I'm really trying to do this across? Is it a broad network where we're just a contract with a payer and we're a provider's hub of care? Or do we have more products wrapped around our particular network? And what does that mean in terms of pricing? And is there differential pricing if an employer uses us exclusively versus an employer using whoever's covered under the benefit? Thinking about applying it on the right side of this visual here, on the payer products and lines of business that you are going to contract with, even to direct to employer considerations. How does that really tie into the elements that are on the center box here with all the arrows sticking out, the 1 through 8 items in terms of, the networks of care, the pricing and the volume indicators? What are we going to do to effectively manage patient populations, navigate across our networks? Are we in fee for service or pay for value? On the left side here, are we starting to move towards value based on upside downside risk? What does that mean? What does it do to our clinical model? What does it do to our analytical requirements to feel a level of comfort on entering into these risks? And on the left side here, some planning considerations is unknowns and uncertainties in the market and potential disruptors that are there. If you had moved actively to a percent of premium or capitation, which isn't so hard to do the mathematics or the analytical aspects, but it's very hard to be able to manage the clinical and the operating risk. And it really requires a network of care and a pop health mindset. Are you really ready for those types of things? What happens if a Medicare for All program comes into play, or even a Medicare reduced age where the commercial market all of a sudden shrinks? What do all these things mean relative to your pricing? And take a holistic look at what you're doing on a go forward basis in 2021 and 2022. Try and do a little tea leaf reading in terms of your relationships with particular payers, the lines of business that you contract with. And what does all this mean relative to your organization on contracting, but also relative to the whole CMS price transparency, understanding the goal is to reduce cost variation between services. And what is your role in that kind of dynamic in the market as whole and relative to your competitors and what you go after in the market? Next slide, please, Mark. The revenue rebalancing thing that we referred to earlier, these are some of the key dynamics involved here, and a little bit of a Zen chart here of balancing. A simple way to think of this is you have a mutual fund, and your mutual fund historically, call it fee-for-service managed care, has really relied on one kind of investment strategy. But now you're really thinking about your portfolio. What is a higher risk and a higher yield opportunity? What is a lower risk, a lower yield opportunity? And it's about finding a balance across the services that your organization offers, across different settings, across different goals, across different service line strategies, and really looking at the dynamics, these multivariate dynamics involved. What are the rate levers that I need to push to achieve my goals on a short-term basis, on a what are the volume levers that I need to push? And that also includes things such as patient retention, new patient acquisition. Are we having patients self-refer out of our system because of availability, access issues? And what are our overall goals? What are services that we are really defining as proprietary and patients really come to us because they want us for the clinical care and they're less concerned about out-of-pocket issues? What are the ones that are much more commoditized today and are going to be increasingly commoditized in the future, and that have low barriers of entry into the market? And start thinking about all that on a 3 to 5 year horizon, anticipating as best you can where the hockey puck is going to be in the future relative to your organization, your specific primary and secondary service areas, where you want to grow in the market, either existing services and capacity, or whether you have very defined strategic growth plans as part of your growth trajectory. Next slide, Mark, please. And then lastly, we take all this together where we've talked about revenue rebalancing, and it gets into what outside of healthcare, and it's called less within healthcare, is really a dynamic pricing model. You're pushing multiple levers, as was shown on the prior slide, to really look at the different aspects of the market that your pricing needs to consider. Competition, price transparency, margin issues. For any of you on the phone who are managed care, I've been a managed care exec at a number of places over the years. And the thing that I always used to hear is we don't need to address our costs. We don't need to address our volumes. We just need managed care to get higher prices and everything will be solved. Well, it's a more complicated world now. And that's a really delimiting type of strategy in the future. But you start putting these aspects in here. What happens if we lose HOPD, or we get a move with our payer contracts towards site neutral reimbursement? A lot of implications there. Payer pressures, which are ever increasing to demonstrate value, and so on and so forth. And you put all this together along with your price transparency, with your consumer essentiality strategies for your organization, as well as how you're going to interface with the market, the different buyers and the users. So the old days, in our point of view, my point of view in particular, is that price transparency was kind of the final, I don't want to use the term nail in the coffin, but the final pebble in the pond, if you will, that's moving our contracting strategies of the last 20, 25 years, more fee for service, more wholesale, more across the board rate increases, to something different. And the something different is going to require different levels of sophistication, people, process, and technology investments for your organization. And to stay on course with what has historically been the comfort level really is probably going to put your organization in a poor position in the market in the future. even if you're a sole community provider in different parts of Georgia, there are certain risks that go into that. And Mark, I think that was the last slide, right? So then time's remaining here. Any questions that the audience has for our team? And thank you for the opportunity to present to Georgia HFMA. Silence is never a good thing.
This is Catherine. There don't appear to be any questions right at the moment. If anybody has any, if you want to put those in real quick, that would be great. Let's just give it a few seconds. But it does not look like we have any questions. So with that being said, thank you all for participating in today's webinar, and thank you to Chris, John, and Mark for sharing your expertise. Oops, now we have a question. Chris, are you going to grab that?
Oh, sure. It's a question.
That's actually for me.
Yeah.
Sorry. Yes, we will be sending out copies of the slide, excuse me, the slides and the presentation and all that type of thing on Friday.
It's a question from a very recognizable name, so thank you.
We'll be sending that out on Friday, all the documentation. So if you're interested in learning more or registering for these sessions, you can check out the events calendar on the Georgia HFMA website. And it looks like that is our only question. So
can I make one final comment, if I can, since there's no question?
Sure, please.
Think about what you've seen today. Talk across your organization, talk with your CFO, talk with your chief strategy or chief consumer officer, and really think about what the longer term implications on price transparency are. I know a lot of our clients still are hoping it gets repealed, but we haven't seen any indicators that that's going to occur at all from a federal level so far in the new administration. And if this is the future, really think about what does this mean, what you heard today relative to your organization and what changes you may need to think about. So thank you again for the opportunity.
Thank you again for joining us today. And that whoops, we got one more. And that concludes our session for today. Everybody have a good afternoon.
Goodbye.
Great, thank you.